Hello everyone, how are you doing? So here is a step-by-step guide to reporting traumatic elbow effusion with occult fractures fragments. So the diagnostic hook, an elbow effusion might look routine on standard X-ray, but missing a tiny occult fracture fragment can lead to devastating long-term joint dysfunction. Are you confident your radiology report captures the subtle signs that surgeons really rely on? In this guide, we would break down the exact search pattern to identify hidden pathology. So the expert masterclass hook, reporting complex elbow trauma require more than just identifying fluid. It's about connecting the dots between a fat pad sign and nearly invisible bone fragments. Most residents struggle with the precise terminology required for these cases. Today, I am showing you a step-by-step reporting framework that ensures you never miss an occult fracture again. So I've just done this case and I am documenting the findings. I will show you what I found. Then you can also follow how we make a report step by step. So the curiosity and precision hook. What if the most critical finding in your patient's elbow scan is only 2 millimeters wide and hiding in plain sight? Occult fracture fragments within a traumatic effusion are frequently overlooked, leading to chronic pain and instability. We are diving deep into the specific imaging planes and the descriptive language needed to create a flawless diagnostic report. So now, this is the case that I just did. So I need you to see what I found here. So you can see this is the posterior elbow, and you can see that there's an effusion with the mid-level internal echoes, and you can see that the effusion is moving, is moving, is moving. So you can see here there are some fracture fragments there. There are small tiny fragments there. You see these fragments, and you can see this all is blood. This is blood there. So this is the posterior elbow, bleeding there in the olecranon fossa there. So you can see here this tiny little fragment that you are seeing there. So these are the things that can be missed on X-ray. So you can see here the X-ray there is not really showing much in terms of these tiny fractures that we have there. These tiny fragments, you see, they are not demonstrated on X-ray. So the X-ray looks normal, but if you look closely, you can see that there are these loose fragments that you can appreciate from there. So you can look at all the bleeding that happened there. So when bleeding happens in a joint space like this, we call that hematorosis. So if you're doing an ultrasound, you should be worried where the blood is all coming from. So you should worry where the blood is coming from. Otherwise, if you're going to overlook, you are going to overlook the subtle fractures, the fragments that we have there, and you will just do the same that someone is going to do report on the X-ray is going to do. So these fractures, ladies and gentlemen, they are a going concern because they are very silent. It's very difficult to visualize them. They are sub-centimeter fractures and very easy to see. To miss, sorry, they are very easy to miss on an ultrasound. So those are what we call the occult fractures. So occultic fractures are a problem in the practice of radiology because if you rely on a single modality, you will definitely miss them. And then the patient is going to have the pain for the longest of times. So they are coming to hospital, they try to go to work, then they can't work because of those fragments. And you see, these fragments can cause localized inflammation, and yet the practitioners will be saying that the x-ray is normal. So it's a huge challenge, ladies and gentlemen, that we have to deal with. It's a huge mountain dealing with occultic fractures. So you can see here, you can see the effusion there. So you can see the effusion. You see how big the effusion is. So it's all blood. This is all blood there. So you can see the high level to middle level internal echoes. So middle level internal echoes inside the blood. So you can see this is not just water. So this guy fell and on the elbow, and you see the effusion there, right round like that. So that's a bleed. How do you report on these guys in your departments? Those who are doing MSK, you are seeing this on a daily basis. How are you reporting on them? Can you write a simple report on your findings? Yes, you've seen this. Are you going to talk about the small fracture fragments, or you are going to chicken out? Are you going to chicken out, or you are going to report on those? Let's talk. Feel free to comment in the comment sections. In this presentation, I am going to give you a simple report on what ought to be done when you are reporting on a suspected case of an occult fracture with the associated hematoma is happening in our case. All this bleeding that is taking place there. So let's move on. I think you have seen the collection. Let's move on now to the next step so that you can internalize what is happening there. So it's a simple report of the findings. So you can see here a moderate anechoic to mildly complex elbow joint effusion is demonstrated within the anterior and posterior recesses, resulting in capsular distension. Within the dependent portion of the joint recess, there are multiple echogenic osseous fragments demonstrating posterior acoustic shadowing consistent with the intra-articular fracture fragments. The cortical outline of the visualized distal humerus or proximal radius demonstrates subtle cortical irregularity, raising suspicion for an occult intra-articular fracture. There is surrounding soft tissue edema adjacent to the joint capsule. The distal biceps tendon, triceps tendon, common flexor tendon, common extensor tendon, radial collateral ligament, and ulnar collateral ligaments appear intact without a sonographic evidence of rupture. No focal muscle tear is identified. No organized hematoma or abscess is demonstrated. Color Doppler demonstrated mild hyperemia around the synovium consistent with the post-traumatic inflammatory changes. So again, ladies and gentlemen, let me repeat for you how you write the simple report on this. A moderate anechoic to mildly complex elbow joint effusion is demonstrated within the anterior and posterior recesses, resulting in capsular distension. Within the dependent portion of the joint recess, there are multiple echogenic osseous fragments demonstrating posterior acoustic shadowing consistent with the intra-articular fragment fractures. The cortical outline of the visualized distal humerus or proximal radius demonstrate subtle cortical irregularity, raising suspicion for occult intra-articular fracture. There is surrounding soft tissue edema adjacent to the joint capsule. The distal biceps tendon, triceps tendon, common flexor tendon, common extensor tendon, radial collateral ligament, ulnar collateral ligament appear intact without sonographic evidence of rupture. No focal muscle T is identified. No organized hematoma or abscess is demonstrated. Color Doppler demonstrates mild epidemia around the synovium consistent with post-traumatic inflammatory changes. So now, what is the impression in this case? Moderate traumatic elbow joint effusion containing multiple intra-articular echogenic fracture fragments. Findings are highly suspicious for an occult intra-articular elbow fracture, despite the absence of an obvious displaced fracture on sonograph. So, in your case, in my case, the X-ray was done. Recommend urgent radiographs if not already obtained. So, if radiographs are negative but clinical suspicion remains high, CT is recommended for fracture characterization, or MRI may be considered to evaluate associated osteochondral, ligamentous, or occult bone injuries. So clinical orthopedic correlation is advised. So this is the impression, and then these are the recommendations that you are supposed to give when you are dealing with a case of suspected occult fractures. Moderate traumatic elbow joint effusion containing multiple intra-articular echogenic fracture fragments. Findings are highly suspicious for an occult intra-articular elbow fracture. Despite the absence of an obvious displaced fracture on sonogram, recommend agent radiograph if not already obtained. If radiographs are negative but clinical suspicion remains high, CT is recommended for fracture characterization, while MRI may be considered to evaluate associated osteochondral, ligamentous, or occult bone fractures. Clinical orthopedic correlation is advised. So now, this is the checklist of the things that you are supposed to work on, or to do, or to not miss when you are reporting on a suspected case of occult fracture. So the reporting checklist: state the amount of effusion, small, moderate, or large. Mention whether the fluid is simple, complex, hemorrhagic, septated. Describe fracture fragments, the number, size if measurable, echogenicity, mobility, acoustic shadowing, and assess cortical irregularity. We should evaluate distal biceps tendon, triceps tendon, the collateral ligaments, the common extensor tendon, common flexor tendon. Then look for soft tissue edema, hematoma, joint capsule distension, the synovial hyperemia. Then recommend appropriate follow-up. So now, in conclusion, ultrasound demonstrate a moderate traumatic elbow joint effusion with multiple intra-articular echogenic fracture fragments and subtle cortical irregularity. These findings are highly suggestive of an occult intra-articular fracture. Ultrasound serves as an excellent bedside tool for detecting fracture-associated joint effusions and loose osseous fragments, particularly when initial radiograph are inconclusive. Correlation with the CT or MRI is recommended for further definitive characterization and treatment planning. So, ladies and gentlemen, this marks the end of this presentation. So this is how you ought to report on occultic fractures. This is ideal for radiologists and sonographers who are friends of MSK. Thank you so much. Don't forget to subscribe to our channel for more. Share, like. I miss your comments, guys. Thank you.